and welcome to Beyond the Scales, That and the Obesity Conversation, where we unravel the complexities of obesity. I'm Emily, and I'm joined by my co-host, Fran.
Hi everyone, we're two medical students on a mission to demystify obesity, as there's so much more to this topic than just a number.
We're joined by a special guest today, Dr Fay Millis, and she is a specialist clinical psychologist in weight management. We're also joined by a regular consultant bariatric surgeon, Mr Lee Humphreys, who's working with us on this podcast.
Nice to see you again, ladies, and thank you very much to Faye for agreeing to join us on this for what will be, I'm sure, one of the most informative episodes we've done so far.
Hi everybody, nice to be here and thanks for having me today.
We're very excited about filming this episode today. Could you start off by telling us more about your role within the weight management service?
Yes, absolutely. So my role is really wide-ranging, and that is partly, I think, as Lee's talked about in previous podcasts, a reflection of how complex obesity is in its presentation and as a disease state. So in terms of the type of model that we use within our weight management service, we very much utilise the whole biopsychosocial model. And I think Lee's talked quite a lot about the bio and some of the psycho and social, but today I can talk quite a bit more about the psychological and the social, I'm sure we'll get to as well. So in terms of the psychological, again, there's so much to talk about. But if I start by just saying a bit about the type of psychological presentation that we see coming into our services and the sort of people that we need to, the sort of people that we work with. First and foremost, in terms of diagnosis that we might see, people are 5.8 times more likely to have depression. They're 1.4 times more likely to have anxiety. They are 3.8 times more likely to have alcohol use and 4.5 times more likely to have an eating disorder. And within that eating disorder bracket, 30% roughly of the people that come through our doors screen positively for something called binge eating disorder and need specialist intervention and help and support around that. In terms of other aspects that we might see, if you're a female with obesity, you are twice as likely to have a label of personality disorder, and the severity of your personality disorder symptoms correlates positively with your level of obesity. So already you can see that there starts to be quite a complicated picture for the people that we see through our service. And on top of that, we absolutely need to make sure that we're trauma informed in terms of working with the group that the population that we see. So if you have had adverse child events, ACEs in your life, then that increases your chance of obesity. And when I talk about ACEs, I'm talking about having experienced abuse or have parents that have perhaps been in prison, divorced, experienced bullying as a child. All of those things are kind of, and others come under the category of ACEs. And if you are unlucky enough to have 4 of those in your life, you have twice the chance of being obese. So again, you can start to build a picture of what people may have experienced in their lives and how complicated people's lives are before they come through into our service. The other thing perhaps to also mention is that if you have ACEs in your life, that can affect your use of healthcare services. One of the things that we know is that if you have ACEs in your life, you are more likely to book primary care appointments, but less likely to attend them. And part of that lack of attendance is around feeling stigmatized and judged and fear of judgment about going to those appointments, which means that you are less likely ultimately to get a timely diagnosis in terms of other diseases or conditions, including cancer. So all things that we really need to bear in mind for people in terms of the journey that they've had before they even come through the doors to weight management and the kinds of difficulties that they might well be experiencing.
Leading on to what you were just talking about with how they struggle sometimes to keep going with regular appointments and things. How does that work with getting into bariatric surgery? Because I understand they must follow, obviously, a weight management plan, and then do that for 2 years, is it? think it's 2 years.
Yeah.
And then you go into surgery. How does that work? Does that prevent them? Does that actually, if they struggle with that, is there kind of more lenience there or no?
So hopefully by the time they get to the point of going on the bariatric pathway, they will have attended and come into our team and learned a lot about weight management. A lot of the kind of non-attendance can be related to stigma, internalized weight stigma bias, and external weight stigma bias as well. So, and unfortunately, that is evident in our healthcare system, as we know. And people's journey to us might have been quite tricky, so they may not have attended all of their appointments because of their experiences with that. However, hopefully by the time they get to the bariatric pathway, they'll have had some really positive experiences within the weight management service, which they will have been in for a considerable period of time. And as a result, their attendances will be there and be improved, and their motivation, hopefully, to be able to know that they've got the support network around them to be able to create change.
I think it's also fair to say, and correct me if I'm wrong, Faye, I know that we screen people actively when they're referred in to the weight management service for certain psychological conditions like binge eating disorders and other things. And I know you try and, if people are scoring highly or there's a high risk of concern there, they may come to you or your colleagues for treatment before they then carry on the rest of the pathway, because it's very difficult for people to engage in a weight management program if those underlying psychological issues aren't addressed early on.
Yeah, absolutely. And we do a screening to make sure that when we have identified any hidden eating disorders that might be prevalent for any individual, and made sure that they get the specialist support. In this particular area, we have the eating disorder service that are commissioned to provide a service for people who screen highly for or screen positively for binge eating disorder. However, we do have a subclinical population who perhaps wouldn't screen highly enough to gain a diagnosis of binge eating disorder, but still need intervention, and we would provide that within our service as well. People generally come on and they do the core program first, which I can talk about in a bit more detail later on, but then they would go on to access some of the more kind of psychologically led interventions after that, and go on and see a clinical psychologist if needed. So in terms of my role, one of the things that a psychologist does within the weight management service is thinks a lot about those psychological presentations that might come in. But the diagnosis is not enough on itself. Just knowing that somebody struggles with depression is not going to give you a straightforward answer into how that links in, perhaps perpetuates and maintains the cycle of weight for the patient and the clients that we see. So it's how it all links in together. And quite often psychologists will bring something called a formulation to team discussions and team MDTs. And what that's designed to do is think about all these different strands, not only the psychological and mental health presentations, but also the sociological, and pair that in with what Lee's already described in terms of the physical presentation as well. So we can really understand and unpick for each individual how it all works.
Yeah, I mean, I think we should point out to listeners at this point that our psychologists are absolutely key members of the specialist weight management program and MDT, and we couldn't do our job properly without them. They really are fundamental to helping our patients. And as Faye's already said, they've often had a very complex, difficult journey before they get to us. So I fully believe that our psychologists are incredibly important members of the team.
Thanks, Lee.
Your screening and the questions that you have leading up to bariatric surgery and figuring out what's going on in the background with each individual patient. It's not to, prevent them or stop them from surgery. It's to help them create a long-term, lifelong plan. Is that correct? I
think that's a great question, Emily, because I think that a lot of patients perceive, maybe before they start the program, that a psychological assessment and other things that we do are there as barriers to surgery, or other treatment. They're not. What we're trying to do is set people up in the correct way to get the most benefit out of the treatment that they eventually end up having. And for me, that's incredibly important. And for example, if you do bariatric surgery on someone with an undiagnosed eating disorder, that can be absolutely disastrous for that patient. In the post-op period, they can become incredibly well, face real problems that if we'd known about and treated beforehand, we could have stopped that from happening. So I think this is a common misconception, and I'll let Fay break that barrier down a little bit.
Yeah, absolutely. I totally agree with Lee. Our role is not to create red flags and to put barriers and blocks in place for people. But if people ultimately decide, with the support of the weight management service, that bariatric surgery is the way forward for that particular individual, then my role as a psychologist is to think about that formulation that I talked about and really unpick what are the key drivers, the key things we need to consider that have created obesity for somebody in their life, and then maintained that, and to make sure that we've excluded or treated successfully any eating disorder or any part of their mental health or any part of their lived experience in society that may be creating difficulty to post-operative success, essentially. And that can include lots of different things. So, for example, I might see two people who perhaps have a diagnosis of bipolar and trauma, but in one assessment I might see that somebody's bipolar condition isn't well managed and perhaps needs to be looked at and thought about, because it will impact on their post-operative care in terms of keeping a stable routine, being able to optimize health. Whereas with the other person perhaps seeking bariatric surgery, it might be that their trauma history is creating emotional eating that hasn't been successfully managed. And actually my job is to think about how we manage their emotional eating and their trauma, and to offer trauma therapy to that effect. So even though two people have perhaps on paper seem to have the same presentation, it might be that there's quite different psychological interventions that are needed to help support. And yes, absolutely, we would not, unless somebody was really raising a concern for us in terms of not being able to manage the surgical process, the build up to it before, and to be able to manage post-operative life, we would be otherwise trying to help support them through that process and be able to facilitate it for them.
So on the whole, it's quite an individualized process when patients come to see you. What should patients expect? How long are the appointments roughly? How does it work?
So the psychology runs throughout as a theme throughout the entire process for weight management. So we don't have one particular model that we work to. So it depends at what point. It depends. The psychological approach depends at each individual point. In our core program, we run several sessions on food and feelings. So that might include work around Michelle May's eating patterns and eating cycles. So we might talk there about dieting, binging, restricting cycles, and we might pick apart some of the patterns that people have perhaps fallen into. We might then talk about the obesogenic environment, which is the environment we currently live in, and all the political, cultural, societal, family, interpersonal influences that create our eating behaviours and the way that we live, which are incredibly powerful and definitely cannot be ignored. So we talk a lot about that. We help people to tune into what physical hunger is as opposed to head hunger, comfort eating, and that would be the start of our discussions with people. Most importantly, we take away the myths that it is a matter of personal responsibility and that they are to blame for their condition or their obesity, because as we know, that is not backed up by science. It is not backed up by research, and we have a lot of research to tell us that view is really unhelpful. Shaming people into thinness, if you like, is utterly inappropriate and actually has really devastating effects on people. One of the things that we often see within our service is people with really high levels of self-hate, shame, and disgust. And we have to work really hard right from the off to build up a different relationship. And perhaps it's the first they've ever had with healthcare professionals, where their weight hasn't been stigmatized in some way. So we spend a lot of time doing that. And then if people go on to some of our other groups, like our emotional eating group or our body image group that we've run in the past, then we would start to think a lot more about, emotional eating, what's behind it, the triggers. We would talk a lot about Denise Radcliffe's model of pausing and thinking through the options. It might involve quite a cognitive behavioural therapy a slant, because we might talk about the triggers and then managing your thoughts and feelings around what triggers people to eat. So we do a lot of that kind of work. And then in individual therapy, we will go on and see people who are perhaps more presenting with more severe symptoms around self-hate, lack of compassion, and really struggling with those aspects. So we use a lot of compassion-focused therapy. We would use a lot of acceptance and commitment therapy. We use EMDR as well, eye movement and desensitization reprocessing therapy. And the list goes on in terms of what we would utilize with people to help them to be able to manage some of those experiences that they've had, really unhelpful experiences.
Patients feel about that individual and group therapy combination? Do you ease them into group therapy, or do you kind of start that straight away?
So the initial intervention we offer, because of the numbers, as well as because of what we know about group therapy and how helpful it can be, it's groups that we offer initially. So people come in and they'll do a core program, which we're just in our service, we're just in the process of reviewing. We know that group therapy can be so powerful because it's sometimes the first time that people have had the opportunity to really come together and think about their weight and think about the things that influence their weight and share their experiences. A lot of the time, people that we see have really been quite insulated and isolated in terms of their experiences, and feel that the shame level means that they can't talk about their experiences because there's such a high level of self-hate and shame and self-blame and internalized weight stigma that it's really difficult actually to be able to open up about that. Having a group of people who are like-minded and had shared similar experiences is priceless in terms of what it can offer. And then mainly down to resources, we will then see if people need further group interventions, which is at the moment it's the emotional eating group that we offer. Then and lots of people really get what they need, and we know that that can create a support network post group and post weight management experience. And we know that people are likely to have better weight related outcomes and better quality of health if they're able to tap into both informal and formal support, particularly after bariatric surgery. So we know how powerful that presence of other people can really be. When people need a more individualized approach is perhaps if they have a particular style of interacting, or social groups for whatever reason create problems psychologically and they're not able to get their needs met through the group. Sometimes the kind of content that people want to share is not appropriate for a group. And so the groups that we tend to run are psychoeducational groups rather than specifically therapy groups. And then the therapy might come later on an individual basis as needed.
And is that therapy available and the group work available after surgery, or do you signpost them to further resources, or what do you do then?
So we do have a post-operative psychology service. So, as with all of these things, our services are hugely overwhelmed with work. And I think that's a reflection of how complicated and complex obesity as a disease state is, and how many things influence that state for healthy well-being. So we do offer a post-operative service. At the moment, it's mainly individual therapy work, but there is always the potential for groups. We know that people post-operatively can really struggle with body image issues. We know that there can be a bit of a time lag between the physical changes that people notice in their bodies and their brain catching up with that. We also know that post-operatively people can really struggle with their relationships because relationships can change, not just individual intimate relationships, but also family and friends. Quite often people are put in certain roles because of the way that they appear, and that can all be challenging. It can lead people to kind of reevaluate the types of relationships that they have. We know, for example, that divorce rates are higher for people who have had surgery, and that people are also perhaps experiencing their bodies in a different way. So they perhaps might become more vulnerable because they're starting to attract attention for the first time in a way that they hadn't become used to, or people don't like the way that they're becoming now because they've served a certain purpose. One of the key things that we know from some of the stigma research is that fat and funny, quotation marks, is a description that is often applied in social media, and people with obesity sadly can often be put in that funny humorous role. So all of these things can come into play. That's just one example. So we offer a service that looks at all of those social relationships, that can identify difficulties if people are struggling with their mental health afterwards, and how people adapt to their lives post-operatively.
One of the things that I hear from patients occasionally is friends and families basically saying to them, "Oh, you're too thin now. You should eat more." And it's a really interesting dynamic. And as you say, that dynamic changes. And as patients post-operatively approach a healthier weight, that the people around them who've known them for a long time are telling them that they look unhealthy, they look ill. So here's you're not eating enough, almost encouraging them to then sort of start to undo some of the work that's been done around the time of surgery. It's a really complex and quite interesting interaction, all of this. I think people think it's really quite straightforward. And, I honestly tell patients that, the surgery is the easy bit. This stuff is far, far more difficult and far more of a long-term problem than the actual surgery itself.
In terms of support, Lee, that you have in your follow-up clinics specifically, do you notice a change in, family members or partners attending with the patient? Or
so, I think my observations are that patients who have support from their families, partners, friends tend to, I hate using the term do better, but tend to have a more straightforward journey and seem to be happier with their outcomes. But I can think of at least 3 or 4 examples of people where they come with a partner and you start to pick up vibes that their partner maybe is not entirely supportive of the process. And that can be slightly awkward sometimes. And certainly then I can recall 2 of those people who post-operatively have ended up actually with their relationships ending because of lots of the things that Fay's discussed. Because, people's relationships do change. When patients' self-confidence, as it does for a lot of patients, improves significantly after surgery, and people particularly who've not really been keen on socializing because they feel ashamed of how they look, all of a sudden these people go from being introverted, staying in the house, doing whatever they do with their partner, to actually, I'm going to go out, I'm going to socialize, I'm going to meet new people, I'm going to do new things. Those are big changes, and they are not always welcome by partners or other members of the family.
Self-esteem and their confidence can be boosted. However, if you bear in mind the psychological complexity for the people that we see, you may well be having to manage somebody who, having to think about somebody who has experienced abuse sexual trauma, and they see changes in their body that are suddenly getting attention in a way that they hadn't anticipated, and that can be terrifying for somebody. So in terms of the type of abuse history, you really want to be checking that out in our pre-operative assessments about how people are going to manage change within their body that might create differences in their relationships, depending on the type of trauma that they've experienced. So for the majority, it can be a fantastic experience and one to really be embraced. For a few people, it can be absolutely terrifying and can lead to them trying to put weight back on or sabotaging the surgical attempts because some of that stuff hasn't been resolved for them psychologically. And also, it can have a link into, as we've already discussed, people's relationships with their current partner, friends and family. Sometimes cultures of feeding, celebration. If you think about food, it's, celebration or commiseration, and when somebody suddenly has to not eat as much, that can be really insulting depending on the culture that you're in. When you go into a restaurant, for example, and you only eat a golf ball sized portion, that can create lots of discussion and questions, and that can feel quite interrogatory sometimes, either from restaurant staff or from your friends that you're there with. And particularly people sometimes come up against quite a lot of stigma about having surgery in the first place. It's the lazy option. It's the easy option. Look at you've gone and got weight loss surgery, without actually really fully understanding how much of how much of a kind of lifelong effect and lifelong structure you have to put into your world to be able to manage the ongoing post-operative lifestyle. It's not an easy option. It's a really difficult, challenging one. So it's really important we know that people psychologically and socially have all the support that they might potentially need post-operatively to make it work.
I just want to extend our thanks to you for joining us on this. I'm really excited by the content. I think it's been a fantastic episode. So thank you very, very much.
Yes, thank you so much.
That's really nice feedback. Thank you. It's been so nice to be part of it today.
If people have questions or have any other topics that they'd like us to talk about in future podcast episodes, please do send us an email.